So, PK, we have you on screen.
Huh? Oh, hi, Dirk. How are you? We have prepared a nice case for you right now. And I just want to have Farhan present this case for you before we get started. Fielder, guys?
Fielder. Fielder's right here.
Farhan.
Oh. Good afternoon, everyone. This is a 65-year-old female with a history of hypertension, hyperlipidemia, and PAD who has had a right SFA intervention in the past. The patient now presents with worsening, non-healing 2 by 2 centimeter ulcer in the dorsal aspect of the right foot, just proximal to the right first toe over the last few weeks. This is Rutherford grade 3, category 5, Fontaine stage 4. The patient actually went to an outside facility and underwent an unsuccessful attempted revascularization of the infrapopliteal vessels via an antegrade approach. So she subsequently saw her podiatrist and was referred here. Next paragraph. On past medical history, you can see hypertension, hyperlipidemia, PAD in the past. She's got a history of Hep C. Next slide, please. On appropriate medications, including aspirin, Plavix, as well as a statin and amlodipine for blood pressure. Past history of smoking. Next slide. On examination, the patient is noted to have a 2 centimeter by 2 centimeter ulcer on the dorsal aspect of the right foot, just proximal to the first toe. No gangrene is noted. She does have diminished pulses in the right lower extremity, 1+ on the DP and Doppler PT pulse. Left lower extremity are normal. Her laboratory data reveals that she's anemic, otherwise all normal. Her right ABI is noted to be 0.38, and her left ABI is 0.96. Next slide, please. Her angiogram reveals that her iliac system is without significant disease. Next slide. You can see that she's undergone previous intervention of the SFA, and the proximal to mid SFA has just mild disease. Next slide. Further down, the mid to distal SFA also just has mild disease. Next slide. And again, at the popliteal level, just mild disease. Next slide. Infrapopliteal, you can see that the patient has an occluded proximal AT. In addition, the TP trunk and PT are also occluded. Next slide. The mid segment of the AT reconstitutes via bridging collaterals, as you can see. Next slide, please. And finally, at the level of the foot, distally, you can see that the AT provides good flow to the DP. The PT in the foot is not noted there, period. So in summary, this is a 65-year-old female with hypertension, hyperlipidemia, and PAD who now presents with a non-healing right foot ulcer in the AT distribution with an abnormal right ABI of 0.38. Her peripheral angiogram reveals severe right infrapopliteal disease, specifically an occluded proximal right AT and with mid right AT reconstitution via bridging collaterals. So today's plan is to perform a right AT intervention via pedal approach.
So Dirk, that's it's a great history, but the point is that I think this guy has had failed, this lady has failed intervention in the past, and there's been multiple dissection planes coming from above. So we just took some pictures to show you. If you can see here, there's just an injection with a diagnostic catheter through, and you can see here that the SFA looks okay. She's got some mild popliteal disease as described, and you can see below knee the anterior tibial really doesn't fill well in this picture. She moves in one of them because of the pain, forgive me. So let me see this one. So here is just a picture of the foot, and again you can see here that the dorsalis pedis is coming down, as you can see. And then here is a picture from above showing the SFA again, showing not much. And I want to show you a better picture because Stephen asked last time the pictures of the actual tibials. And you can see here in multiple views. Here's one view showing that the anterior tibial takes off, looks to be a bridging collateral, and then coming down or a dissection plane of old. And from below, you see that the collateral filling the anterior tibial in the mid-distal tibial region. And then we went to another view here down below to show you better. And again, you can see here, I guess this is negative angiography. Let me go here, the next one. So you can see here at the level of the foot, it's very, very slow filling, but you can see it clearly, it runs all the way into the area of concern. So angiosomally, it's actually the right vessel to approach. So here's the contralateral view that Stephen had requested, and you can see here the anterior tibial is there, and that really now more and more looks like a collateral rather than a true vessel. And then as you go down further, you see here, oh, she moves there because of the pain. You can see here very, very clearly that she really does not have any true straight line flow, just all collateralization to that point. So at this stage, what we decided to do was we did ultrasound-guided tibial access. And I just want to show everybody what we did. So under ultrasound, we just advanced the wire after we entered the vessel. This is basically a micropuncture wire over which we exchanged out for we confirmed the position, over which we exchanged out for a sparticle wire. And then can somebody remove this mask, please? And then what we did was we went ahead and placed the 018 Trailblazer. Remove the mask, I can't talk. Thank you.
Yeah, I got it.
So that's where we're at right now. And then what we're going to do is we're just going to go ahead and wire from below and above. And wire of choice right now, we're starting with the hydrophilic wire from below and just seeing how it goes. So I just welcome any suggestion from the panel while we continue to work. Little die from above? No, Ray has it.
Okay, was it possible to use
Advance?
this bridging collateral to perform a retrograde recanalization attempt,
Good.
or was it impossible to get through the big collateral?
Well,
You can avoid a puncture distally.
you know, we did not try to do antegrade here because we saw the films and there was multiple dissection planes. And you can see here, this wire, this hydrophilic wire is not going to cut it. So therefore, we said, let's go with the primary retrograde access. But our plan would be, as you can see, we put an 018 Trailblazer. We don't have the Cook pedal sheath, the Confianza. We don't have the Cook pedal sheath. So we're hoping that we can actually traverse from down below. And if we can't traverse from down below, I'm hopeful that we can traverse from below and above and maybe do a cart or a reverse cart technique to be able to break through the dissection planes.
You know, PK, I think it's a good concept to come early retrograde because you do have a large collateral that's reforming the AT exactly where your catheter is. Bearing in mind that the lesion is actually a fairly long lesion, maybe 15 centimeters, and you don't expect a very prolonged patency for this lesion. And when that lesion occludes, the collateral is going to keep the vessel open. You did an antegrade dissection. There's a very good chance you take away that collateral, and so you're really thinking about preserving your next option if that lesion goes down in time.
Yeah, I agree with you, Stephen. You know, the collateral is the lifeline of this entire foot. So I think at this stage, we're going to just try with a little bit stiffer wires. I'm just curious, what are the wires you go to below the knee or the panel? We are going with an 014 coronary wire at this stage to try to steer it away from that collateral if I can. Oh, collateral.
I think this is a good place for a moderate tip load, like a 12-gram tip load.
Track it.
What are you using there?
Right. We're actually using a coronary wire here. Stop. We're actually using a coronary wire here called a Confianza, which seems to be finding the channel here. Oh, that's not it. Moving quite well. Track. Okay, get it off the bone. Oh, don't move, my love. Don't move.
Ray puff.
Little puff, Ray. So I think this is an advantage. We have a catheter down below at the level of the. Nah, I don't like it. I think it's in a spiral. There it is. All right, good. Track it now.
Hold it.
Wait, hold on.
Yeah, hold it.
Hold the wire straight. Okay. We're going to track it up. Okay, hold it. No. All right, track. So I think we were able to get through so far above. Okay, come down below now. Show me above. Show me above, Ray.
Ray puff.
Ray, a little puff. I think at this stage it may be worthwhile to switch for a hydrophilic wire and see whether we can get in. Like, give me a hydrophilic wire. Fielder, please. Well, you could also try the command. I mean, I don't know, do you guys use a lot of the command wire in this kind of situation?
Yeah, I personally like this, not to start immediately with a CTO wire, but I prefer these kind of hybrid wires to do, like the command or command extra support that you mentioned. in my hands at least. The nice nitinol at the tip, and then the more supportive and rigid shaft in Durasteel is for me the choice number one to tackle this kind of lesions.
I know you always talk about that helicopter type crossing. There it is, fine, beautiful. All right, show me the catheter. Let's see whether we can do what Andre does, which I've never been able to do. Let me see. Any tips here, Dirk? I know you and Andre have done that. Oh, there we go. Wow. Oh, my God. Crack it up.
PK, you make it look so easy.
Wait, you're not railing. You're not
this
railing.
is like a poker player who says he's never good at poker.
Yeah.
So let's see here.
So this is a pre-recorded scene.
No, it's not going. No, it's
Probably was practicing for the last months.
Okay, we're just going to push the wire up. We're going to see whether we can take this all the way down. No, it's not going. So walk this out. You want to try with a fine cross here? Push the wire a little more, Vishal. Wait. Actually, we can always do the safari, not come from above. Let me push the catheter from above. Flora? Flora? Rail the wire, guys. So what we're going to try to do now is just meet the two down below at the level, make it life a little bit easier. And see whether we can just, there we go. There you go. All right, now push, push. All right, great. All right, wonderful. Look, now just push the wire out, Michelle. It should go no problem. Wire's all the way up? Okay. So why don't you walk that out now, Karthik? Yeah. And then what we can do is...
Why don't you just get the external length of wire? Just keep pushing.
No, you have to walk that out. Yep. Well, now what we're going to do is we're going to walk out the Trailblazer and just push the wire. Walk the Trailblazer out. Flora? And what we're going to do is just push the wire all the way up. Walk the Trailblazer out, guys.
Yeah, we are. Yeah.
Okay, there you go. And then just keep pushing the wire.
So PK, what's your next step? Are you considering to perform atherectomy here? It's a pretty big vessel.
Yeah, so that's what now that we cross this, the multiple dissection planes, approximately, the question is, would you guys want to do a, yep, I got the wire. Would you guys want to, yep.
I'll clamp the wire on this side.
Yeah, put a clamp on that. Should we do a laser here? That was our plan, to do a 0.9 laser, followed by a balloon. Flora?
Well,
We can
but
pull the wire.
you
Pull the wire.
are already
Pull the wire.
across with a support catheter, which has almost the same outer dimension as a 0.9 millimeter laser. So if laser, then I would use a bigger one, or I would use a Phoenix or whatever kind of atherectomy system here. It does not look so much calcified, so that you can use every kind of atherectomy device which is not really dedicated to calcium.
Okay. So now the question is, so now we have a similar, like a safari type technique. The issue is, I'm just going to pull out this catheter. Flora? I'm just going to pull out this catheter now. So our catheter is out. Now we just need to get a 014 balloon, or just we can load the laser. You've got the wire all the way down? I don't like pulling the wire without balloon support.
Why don't you
So
just put a 014, you can put the same trail.
Personally, as there is not a lot of evidence using these debulking systems even in the FEMPOP area, there is even less evidence to use it in the below the knee area. So I'm completely not in favor of using these kind of devices, and the plain old balloon angioplasty. You can discuss with drug-coated balloons or not, but seems to me a more straightforward and easy way of tackling these kind of occlusions.
With an accordingly high restenosis rate, yeah.
And you don't have this with atherectomy?
It's unknown. At least we have one potential solution to overcome also the limitation of DCB. I will show you during my talk that there are some studies ongoing evaluating the combination of atherectomy plus DCB. That would be one way to go in this long lesion, because the other solution, implanting multiple DES, is not the best one, because we are dealing with a very long lesion. Yeah.
And I think that there are a wide range of atherectomy devices, and they have varying levels of support. There is some support for some of them. Definitively is a large data set, including CLI patients with below knee hypertension data as well, which is a core lab adjudicated trial. So I think
give me a trailblazer.
I'm looking at data. I agree. There's a
give me
real
the,
scarcity of data for atherectomy, but there's some. There's some out there.
Get the laser ready.
I think what would be good to discuss, and what you mentioned, Kuhn, is should we consider adjuncts to improve the patency of a single vessel runoff, a large dominant vessel, in a patient who is not, who's likely to survive for a decent amount of time? And what are the options available in the US here, Brian? What's available for below the knee?
Wait.
No?
Angioplasty.
Are we in the right vessel?
Yeah,
Show me that.
Do you think a bullfrog would, in this case, would it be possible as a?
Probably.
I mean, it's dexamethasone.
I mean, at the end of the day, this type of lesion is would be the almost typical study case we are looking for let's say, for the Lutonics below the knee trial, for instance, or for the limbo bullfrog project. So I think it's a typical lesion where we currently don't know finally what is the solution, but I think we have several options which are currently under investigation. Marian?
I would have classified this patient for.
So Dirk, now we've just exchanged the trailblazer down, and I think, as Andre always says,
just a second. Can you switch on the microphone for Marian? Okay.
So I would have classified that in our trial as a bullfrog case because there is no calcium there. It's a long lesion. I think it would be nice to inject dexamethasone. So I think that would, in our mind, be an ideal candidate for what Stephen has mentioned. And we do not have, as we are discussing, we do not have the final solution right now.
Yeah. So PK, we are back with you.
Oh, no, please. The discussion is phenomenal. I just wanted to ask the panel that now, would you guys do laser on this or just balloon, or after having crossed, what would be the right thing to do?
Well, nobody knows what's the right thing to do. So, you decide what you're going to do.
Well, I already know what I'm doing, so I'm just curious on whether you would have done the same thing.
Well, I think. I can see the laser already arriving. So I would say that's certainly one option. I think what Thomas Thomas wants to make the point during the talk, so I shouldn't go too much into it. But I think one of the failure modes of below the knee angioplasty is probably also recoil due to a lot of plaque burden in these arteries, particularly in these long occlusions. And so I think from a concept perspective, removing plaque by whatever means is probably a good concept, which then likely will need to be followed up by some sort of drug delivery or additional treatment. The problem is we don't know at the moment whether our tools are doing the job or not, but I would think the laser is certainly an option. But I would agree with Thomas, I would go for something larger than the 0.9 laser to make a reasonable debulking here.
So we're going to start, we didn't know because of the dissection on what size to choose, so we felt let's start with a 0.9 and then take it from there. So we'll start with a 0.9. If we need to upgrade, we will. So here we go. Ready? On, guys. Dirk, any tips on what in terms of the panel on what's the fluency and the rate that you guys normally start with in these laser procedures?
Any comments?
I usually start 45 and increase by about 20 each time. You're running about 3 passes before shooting a picture.
I couldn't hear him.
I typically start at 45 and then bump up to 65, all the way to 80 with the 0.9. Basically several passes and then you reassess. I think then thinking about atherectomy, there's obviously a lot of, I agree with the concept of using atherectomy for these occlusions. If it was just a stenosis, maybe I would feel a little differently, but there are obviously multiple devices that can reach even the ankle level. Excisional atherectomy, which is my preferred atherectomy, there are devices that go all the way to the foot, although I will say it's probably best used at the trifurcation in the proximal third, whereas laser, I think, does a pretty good job at these type of straight occlusions that are fairly soft in nature. So I think
Off,
lasers,
come back up.
Laser's probably a good option here.
Now, would you guys go up and make another run at a higher fluency and rate?
Yeah,
I think
definitely.
so. Yeah, especially since you're using maybe an undersized laser, it's probably not a bad idea.
So, so PK, maybe that's
60.
again the moment where you want to take a little bit more time. Yeah. So I learned the ablation speed of a laser is about 1 millimeter per second.
Off.
So maybe you take time. We put you on the side screen and we go on with the lecture, and then we come back to you.
Absolutely. Thank you, Dirk. We'll be working here, and we'll show you the final result.
Perfect.
Thank you.
So, thank you very much, Marianne. We are back with PK in the lab.
So Dirk, thank you again. So what we did was, exactly as the panel suggested, we decided to upgrade the laser after the first pass. And I just want to show you how it looked. Forgive me, I took out the sheath because she was having a lot of pain. So here's after the first 0.9 laser, after we made two runs, and you can see there's a little bit of flow, the collateral is still preserved. So then what we did was we went with the 1.4 very, very slowly all the way down, really trying not to embolize or anything like that. So we did this all the way down, and then we decided to go with a 3035 210 balloon. She had tremendous pain up top when we were inflating, but we left it up for the duration of part of Marianne's talk and Thomas's talk. And then right after that, we took a picture. This is with the wire down. And you can see here, forgive me again, there you go, beautiful. So yeah, she has a nice flow down, all the way down. Then we decided, we took the wire out. This is with the wire. You can see the foot is filling really well, and the arch also forms, which again is very encouraging for her. And then let me show you the pictures without the wire. We pulled the wire out, and then we took a shot to show again that we have wonderful flow in the proximal. I'm sure there are dissections, but I think at this stage we're not going to put a drug-coated stent right now. And I think you can see the collateral is still preserved. That Dr. Kuhn was saying was so important in keeping this leg alive. And then we took a shot of the foot. And I think we're going to be very encouraged that, actually, I got a better picture here. We're going to be very encouraged that she's going to do quite well. So again, I thank you for the support, and thank you for all the great suggestions. Thank you.
Yeah, I think a beautiful result, PK. Any comments? Marianne still wants to make.
May I ask you a question? Why do you not want to go over the plantar arch and reopen the posterior? Because we were talking that this lady only have one vessel, so why not spend some more time and open the posterior?
Oh, absolutely. I think we definitely will. I mean, I think at this stage, it's just for the live case, we wanted to demonstrate this. We will 100% now with that kind of flow. We can take a picture further up top and then see if there's an osteum of the posterior tibial and go after it. Or if we need to come through the plantar loop, we can do that as well with an antegrade stick. But that's a very important suggestion for a global revascularization.
Maybe a comment from my side. I don't know if everybody would agree to do that through the plantar loop. Personally, I would not do it because I think I would first try everything to do it antegrade because I don't think the clinical situation really gives a strong direction that we need to do it. And going through the plantar, at least we've seen a number of occlusions probably due to the friction of the devices and so on.
I would also try it from antegrade before. Yeah. It's just a matter of discussion what everybody thinks and would suggest. Yeah. Just I think it's a matter of discussion. Leave this with one vessel or try also to reopen the second one. How we can do that? We have now installed the blood flow 41. Should we leave it? Should we be sufficient and come back if the wound is not healing, or try to reach the optimal or the most optimal result we can?
But maybe we make a quick poll on the panel. I mean, in this scenario, who would go for, let's say, a single vessel only during the one procedure and reserve it for a second procedure? Raise your hand. And who would put one? Just one vessel and stop here? And who would do it all in once? Okay. So I think that's still discussable, right? I mean, whether
make about that is we don't bypass to multiple vessels when we do bypass. We only bypass to one, but we're getting a different level of perfusion when we bring a saphenous vein down to a tibial target. So I tend to sort of judge how dramatic my change was from pre-op to post-op after that one vessel. And typically I would try from above to get a couple of vessels open, but I would definitely reserve the pedal loop maneuvers till I see that this wound isn't healing and the problem.
So Dirk,
one of the problems is how the foot it looks like, you know, how the disease is advanced. So at that stage you can decide, this is my last option, I have to do everything in one stage, or I can postpone and see how it's going.
So what we're going to do, and I think there's a great, this is the shot to show you there is a option to go antegrade, posterior tibial. Obviously I wasn't honestly concentrating on it initially. And like Marianne said, there is a channel that I think we will be able to get through. Yeah. But I think what we're going to do is, obviously for the sake of time, we will stop here now. And what we'll do is we'll see her back in clinic. We follow them weekly, and then with our wound clinic as well here at Sinai. And then based on how she's looking, we'll make that decision. But clearly there is an antegrade option here. And to Brian's point, if you see the pre-shot versus the post, I mean, the flow is torrential at this stage. And I think we was very happy, like Dr. Coombs said, that we did not lose that collateral as well.
Yeah.
So overall, it will be okay.
Dr. Bister still wants to?
Here would be very interesting to have, for example, these devices that Dr. Montero Baker showed, where we know exactly the oxygen saturation, and then we could decide to go forward or to stop here.
Yeah.
Okay, perfect discussion. Thank you very much
Thank
for the
you
nice
guys. Thanks for everything.
case. And so I would.